given probably gives me a slant of how sometimes the system really is working. Lots to do with policy and procedures, lots to do, the higher I think people get, the more it's about staff than it is consumers, because that's kind of the priority, to help support staff take care of consumers. Lots about contracts and monitoring and tracking. So academics, that's obviously comes into play when we talk about our credentials or our experience. I've actually learned a lot through volunteerism as well. I think that what we do on our own time can also help us with our experience. And then I'll share with you kind of at the front end. I don't always do this because sometimes it's just not helpful to the conversation. But I have lived experience. I have been a consumer in a number of different systems as somebody with bipolar illness. And so this is NAMI to me is a really special group. And so I think it's a place where I do want to disclose that. And so I also would encourage you to think about, you know, are there some life experiences that really help you and have helped you learn about navigating the mental health system? I would probably say that I've learned more through being a consumer than I have, you know, taking some very professional college classes. My college wouldn't appreciate me saying that probably, but that's kind of the real deal. So why is it important? We're going to cover why is it important to understand and navigate the mental health system, a little bit about trauma and drama. I put that there because I think that is the life of being a family member or somebody that's going through the system. It can be very traumatic, and it just sometimes it's just riding the wave of drama. And so we'll go into that a bit. And then I'm going to try to share some concepts and terms and a bit about self-managed care, because if we are going to be in this for the long haul, which, you know, rarely is it all about brief intervention. I love brief interventions concepts. You know, you kind of get in, do a little bit of, you know, counseling and get out. That's not really the experience I have. I have, you know, it's more long-term. It's more requiring some sustainability techniques. And then some resources. I have some great resources, but you're also hearing about the two best ones. MHA and NAMI are my favorite two. They're my go-to, and they're the organizations that I tell everybody about. So that's what I have in mind today with our time together. I hope that's what you came to this workshop about. This is what I think people face. This is so powerful. This image to me is scary. It's confusing. It's got some despair in it. And the family members and people that I help, I think feel this a lot. I don't know if you identify with it, but this has been my experience, that trying to figure out the mental health system. And by the way, I'm not saying I have it all figured out, but I try to figure it out. That's what I spend a lot of time doing, and I try to help others. But like, where do you begin? And then when you kind of start, then it feels like there's just another corner and another corner. And then which direction? Because systems change and the people change and the policies change. And I think this is, and I just think it's a powerful image. And I try to tell, I know my colleagues and my profession, that this is what it's like unless you be clear or unless you do X, Y, or Z. So that's kind of what I advocate, is to help people with it, with this feeling. Why does it matter? Well, it's because mental health issues are all around us. Whether you have a severe and persistent mental illness or you are experiencing stress, the amount of people that have a mental health condition, I have some of the numbers on the next slide, but basically they're all enhanced, I think, because of COVID-19. But there's no single cause for mental illness. You know, there's lots of there's lots of factors that kind of go into this, and no one event causes it. But we do know that it's possible that what somebody had experienced in their childhood can contribute, that if there are chronic medical conditions in addition to a mental health condition that can contribute. Some people will say there's a little bit of biology and genetics involved. If somebody has a history of alcohol or recreational drugs, if there's that loneliness and people are socially isolated, which of course everybody is feeling now, or we're coming out of that, aren't we? We're kind of in a recovery from that, but still, those things are not good for mental health, feeling lonely and socially isolated. So I think just knowing that, again, that there are lots of reasons that people can have a mental health condition. It's no one reason is important, because some of our parents or loved ones had grown up in, you know, generations where people were blamed or thought that they contributed, and this is a much healthier definition and more accurate definition. The numbers, of course, if we're a group, we don't necessarily need to know the numbers because we know it's affected our families or ourselves. But it is good to know that we're not alone, because there are over 200 classified types of mental illness. That's a lot. 1 in 5 will experience a mental illness each year. And then if you're working with some kind of subcategories, like people that are in jail, people that serious mental illness like schizophrenia and bipolar major depression, here's some numbers for you. When we start talking about people that have a mental illness and a substance abuse disorder, then the numbers, it's really hard to track. It kind of gets a little fuzzy, but I would say that it's, you know, really high. At our clinic, for example, we're a small little clinic, but I would say more than half. Other people would argue and say it's probably 70%, but many, many people try to use substances to as their own medication and to try to help with their illness. So the stigma of being a family member, this just as a little support group between us, many people are either perceived as maybe a meddler. So suppose you're trying to get involved with your loved one's mental health treatment or their hospitalization. Have you ever felt like somebody's just seen you as kind of a busybody, or, you know, meddling in I'm seeing some nods, you know, getting involved, or that you're, you know, yes, you do, or you want to say something? Susan, you're identifying, you can unmute.
I had my son's attorney refer to me as the micromanaging mother, you know.
Micromanaging mother, MMM, yeah. And how, yeah, there's many labels, right? And so, yeah, so you can identify with this.
Yeah,
right, Susan?
it's very, very difficult when you have an adult child.
Yes.
And what I find is, I feel like all of his help is like in silos, you know, and nobody wants to explain what they're actually doing, you know.
Yes. Yes.
And so yeah, I don't know if you're able to. I just find it kind of crazy making, you know, that I really would like to see him get help. I'm on the island of Hawaii. I just find the services very poor here.
Mm-hmm.
And yeah, part of attending these workshops. I mean, I'm a member of NAMI, but I just, yeah, I want to know how can it, I feel like that person in front of the maze, you know, how can he really get help? you know, and where
Okay.
is it? Yeah. So,
Okay, so let me see if I can help with that a bit, but I'm glad I'm on target here that there is really stigma of being a family member, right? I mean, I hear it in my own field. I hear it when people are, talking about a case, a case, and they're talking about the parents or the mother called or the this or the that. And it does sometimes have a tone of kind of like, well, why would they be involved? Or that maybe they're annoying or they're, being intrusive. So I think I'm hoping that we can get at, just like there's stigma with having a mental illness, there is stigma of being a family member. So that's what I want to get to a bit. And micromanaging, so it's a way to deflect. It's a way to, it's kind of more about the other person sometimes when they give us these labels. What I want the theme today to be is kind of that, we want to get off this merry-go-round. What I see happening a lot, and I'm sure that you can feel it, is that it's like going around in circles, just going around and around and around. So part of what we want to do is really kind of the linking and syncing. We have an administrator, Eddie Mercer, who will talk about siloization, that, many departments and clinics and providers are just, it's kind of siloed. All the services are siloed. And so how are we linking and syncing, and how are we collaborating? And because the person that loses here is the consumer, definitely the client or consumer. And so hopefully we're addressing that now. So the many hats that we wear, this is much more of a positive framework than this meddling kind of framework. So I think that we want to focus on being advocates, that, we want to talk about, does my loved one have questions or concerns? And then are we concerned about the quality of care? So really raising up the title of advocate, that advocate, and our advocacy movement is way behind, for example, developmental disability movement or other movements, but we still have a mental health advocacy movement, and we need to be seen as advocates for our loved one. We also are educators. How and when do I share my rich and extensive knowledge and things that I want to educate somebody about? The family members I've worked with have often been people that I can get information from, people that can be helpful, but I have to see them as, an educator. I have to view them as and respect them as, for example, a mentor. I've met some people, this is the 4th state I've worked in. This is the only state I will die here, so I'm not going to another state, but I have found that some family members I've met, they've taught me about the system, they've taught me about the culture, they've taught me about not only their loved one, but just they've been kind of, in some ways, could kind of taken me under their wing. And, but see, I have to have ego strength enough to be able to accept that, right? And so not every provider is open to that, but I would encourage our family members to see, we need to see ourselves as advocates, educators, and mentors, because we have just as valuable information as a clinician or a hospital person or some kind of provider. And we are providers. We have done everything from provide shelter to our loved ones, to helping them with their medication, to transporting them all over the place, to provide crisis intervention, to helping with socialization, managing their finances, all those things, right? So we are really a provider of mental health services too. I was so happy to have our keynote, and part of what she reminds me of is how this is another thing that I think we have to advocate for, and that has to do with the cultural connection of if you have a loved one that has some cultural values that maybe are not recognized in their treatment plan. I'm going to talk about a treatment plan in a minute, but and I always I've been taught to use the phrase about the host culture. I love that she said, it's not really about the host culture. We are the root. And I get that. I like that. But I find that sometimes, even though some places have been trained in cultural competency, now it's really about cultural humility. That's kind of the framework. But there's a real difference when you are working with the consumer that is relating to their culture and the programming is around their culture versus just kind of cookie cutter programming or cookie cutter treatment plans. And so I would encourage you to help make sure that there is something that's representing the culture of the client. Trauma-informed care. This is something that, and the state of Hawaii has gotten a lot of consultation on this. I saw some bills in the legislature recently about other systems getting some trauma-informed care training. And so you may be dealing with a provider that doesn't know anything about trauma-informed care, but you should know about trauma-informed care because these are the things that really make treatment a lot harder for our loved ones. But the core values of trauma-informed care is that there is some safety, that the physical and emotional, the environment is safe. And many places, it doesn't feel safe. And so it's already, remember, what's happening is that the mental illness can be kind of traumatic already, right? And then if you add that the environment doesn't feel safe, then that's trauma on trauma. So in a way, sometimes going through the mental health system can be traumatic, not only for the family member, but for the client. And, you know, in trauma-informed care, we want to work on building those relationships. But sometimes if the environment is not informed about trauma-informed care, then it feels like there's not trust. It doesn't feel like there's many choices or collaboration or empowerment. So this is important to know that this is a feature of, in a way, sometimes care if the provider is not really into TIC, because again, we don't want to traumatize the individual more and more as we're trying to provide treatment. So this is one that really kind of scares me, is that no matter who we are, family member, friend, neighbor, provider, hospital, we want to really do what we can to pay attention to these 5 core values with our loved one, because these are all things that can add more trauma, and there's already trauma. So this kind of gets back to maybe Susan's point about, so, I mean, what do we do about this? You all know about the problem, but this, I'm hoping, could provide some help. So one of the key points would be to be able to be a member of the treatment team. Now, the challenge here is not every consumer wants you to be a member of the treatment team. So sometimes you have to arrange this and agree, you know, when the person is well enough to say, okay, so for example, assign consent. When do you do that? You do it when they're well enough to say, sure, I'll let my mom have information, or yeah, I'll let my sister, because sometimes when you're trying to do that, when the person is very ill, you're not going to get that signature. And so the provider is going to be really closed about giving you any information. So the best time is when somebody's, you know, pretty stable and is willing to say, yeah, I would like you, you know, to be given some information, or my case manager can call you if I get in trouble, or, you know, because as adults, they have the right to say no. So, and in a treatment team, it's usually the case manager, the MD, and the consumer. But absolutely, that could be a family member. You just have to make sure that the consumer is saying, sure, you know, you're part of my treatment team. But everybody has some kind of recovery plan or treatment team plan. And so that's a part of treatment. And it's very helpful if something to do with family is in that plan, because then that provider is going to relate to you somehow. And I personally think the strongest treatment plans are those that say something about, a family connection. I'm going to, if I'm the case manager, I'm working with that consumer on, so what does that family connection look like for you? Well, I'm going to try to go over to the parents, every couple of weeks for dinner. Okay, what else does it look like? Well, I'm going to try to, maybe when we have these meetings, I'll invite my mom, or now, maybe since we're teleworking, we could call. Okay, and it's written down. It's kind of having something written down and documented is very helpful, because the consumer signs off on it and the doctor signs off on it. Documentation, keep a notebook of the who, when, what. That sounds like I'm being suspicious, but I've taken care of people with physical problems, and then I've taken care of people that have a mental illness. And I'll tell you, I write everything down, who I talk to, when, why, what. I just take it's just a little composition book. And it's the best thing you can do for yourself, is because it will feel like that merry-go-round, who I talk to, when, where, what, the date, the time, because you will want to, if they don't know your name, and they should, by the time you're in this system, you want to make sure people understand who you are and your name, but you want to make sure that you understand the different people that are connecting to your loved one. And I'll tell you some of the key people in the next slide, but documentation is very, very helpful, so that you can say, I spoke to Susie's case manager on Tuesday, and I was told that the doctor would call me back the following day, and I haven't heard anything, and you just keep beating that until, you get what you are trying to achieve. So some of the main lingo that is critical is, and this would have to do, Susan, too, on the Hawaii island or neighbor islands, whatever neighbor island. So this is really statewide information, but like CMO, crisis mobile outreach. So, and I don't know if some of you have used this or you've called, but a crisis mobile outreach team is when somebody comes out, ideally it's within an hour, to a situation that when you feel like you are, you're past your scope, you're out of your league to be handling the crisis. So, there's arguments and difficulties that we all have in our families, but then you're actually worried that somebody's not doing too well to where you're thinking, I need a professional to kind of deal with this. You don't feel like it's so unsafe that you want to call the police, but you want a mental health professional basically to come to on site, to your home or something. And so there is a crisis mobile outreach service, which is very helpful, where people will come and they will assess what's going on, and they can, they'll kind of, if you will, talk down the person and have a conversation about what's going on. And if the person needs to leave, like maybe go to a crisis shelter, do something else, they can help with that. All this is through the Hawaii Cares line, which I have at the end of the slideshow. So I'll tell you how to get to that. You may be familiar with terms like MH1, 2, 3, 4, 5, 6. They all have a slightly different definition, but basically they have to do with hospitalizations and ones that relate to people not wanting to go into the hospital. Hawaii is the only state that I know of that is quite like we are. Whereas there are other states that if you were to walk by some of the people that we literally walk or step over, and they looked like they do here, you could probably get them you could probably get them in the hospital. You could get them in the hospital much easier than here. Here, and where that comes from, I mean, I guess a lot of lobbying by attorneys, and a lot of people have, in the name of protecting people's civil rights and personal rights, then it is very hard to get somebody in the hospital that doesn't want to go. And so the consequence of that is that, we see our streets covered with people that are in what I would consider really unhealthy, kind of life-altering circumstances. I mean, really sick. So that's very hard to see and to deal with. And that's like more than a workshop. That's like, a couple days discussion about rights and involuntary commitment. And we have a state task force on that. A lot of people are trying to look at that issue with compassion, but also with keeping people's rights.
Kathleen, can I ask a quick question here?
Yeah.
Okay, so I have tried to get someone help that is on the street.
Yeah.
And it was difficult. I did explain that they had a mental health issue, but but more than that, they had a very, very dangerous leg wound.
Yeah.
So in your experience, is it easier to get that person help if I hadn't mentioned the mental health component, and I had just said to 911, oh, I need an ambulance here because this person is on the street with a huge leg wound? Would the response have been faster and easier?
That's a good question, Jerry. I don't think saying they have a mental illness necessarily slows them down, but I would probably, in that situation, and I've been there, I think I would probably go to some of the experts in that very situation are Hawaii Health and Harm Reduction, HHHRC, and IHS, where they will come out then with a nurse to help with the wound. And then if the person's willing, they might even be able to provide some medication, psychiatric and medical. So sometimes I've called them first, if it's or the 911, just to try to get an ambulance and say, this is really urgent. The person is, they're so wounded that their wound is, I mean, this is what I know it sounds gross, but I've said, it's a public safety hazard because it's oozing all over the bus bench. And so this person, please come out and help them. I mean, I don't know how many people are near Chinatown, but my husband has a little business in Chinatown. I was down there recently and I was shocked. And a lot of it is because it's quarantine. A lot of people are kind of not there. So the only people that are there are people that are struggling and homeless. And it just was so sad. So yeah, and what I saw then there was just police around giving them tickets. So I thought, wow, if we could actually have, some more outreach workers and, people helping them, right? Nurses, doctors, wouldn't that be more efficient and more humane? So I guess back to your question, whoever's fastest, 911, whatever homeless outreach team is designated to that area, I'd call anybody and everybody.
Yeah, I felt like I was getting kind of the runaround from 911, like when I was trying to get them to send an ambulance out because it was on the street. So I guess I'll if I run into that situation again, I'll reach out to either IHS or Hawaii Health and Harm Reduction.
Yeah, I would give them a try. Yeah, they're both awesome at, and that's their specialty too. is kind of street doctoring and street meds. Yeah. Isn't that sad though, that you'd feel like you get the runaround by 911, and they don't want to pick up somebody like that. They don't want to treat somebody like that. And even the police, if you call the police, sometimes it varies though. I called the police a couple weeks ago to help somebody, and they were great. Of course, they wanted me to do more than they really wanted me to help because they weren't sure what to do. And I was like, well, he's bothering a business, so I will help him get away from the business, and he needs to move down there with his cart. So sometimes they don't really know what to do. Go ahead, Susan.
Is there those kind of Hawaii harm reduction? Is that on the island of Hawaii? Is there, or is it only limited to the island of Oahu?
You know, I thought they were going to spread out. They're a big place here on Oahu, but I would go to their website, Hawaii Health and Harm Reduction, and Heather Lusk is the CEO or executive director, whatever. I would find out, because if they don't have one, they would know who is kind of their counterpart sort of people.
Are you able to briefly state what these MH levels mean so that?
Sure. There's actually, let me bump over here to, this would be kind of the main definition, is that you have to be dangerous to others or dangerous to yourself. So this would be, I mean, that's the gist of these. And so you have to be substantially, physically or emotionally, it means likely to do, you have to, and believe me, this is so strict. This is what the law says. But again, I think we've all seen people that look like they're half dead on the street or the bus stop, and they're still not going to get picked up. And I've heard family members say that, you know, they have felt very endangered, but their loved one is still not going to get picked up. So this is the legal language, but it is very hard to enforce. The best thing to do is really to try to work with the doctor. There are some doctors that will, you know, try, but many people have felt hopeless about, I mean, I'm just going to be blunt, hopeless about trying to get somebody in the hospital against their will. So it's really got to do with
something.
Yes.
Hi, my name's Karin.
Hi.
You know, it's not just the doctor. The doctor has to write something that then a judge will actually do.
Yes,
And
thank you.
so that is the issue that I have, is often the doctor will be willing, but the doctor will say, you know what, the judge isn't going to approve this.
Yes,
So
thank you.
just wanted to say that.
Thank you for adding that. Yeah, it's beyond the doctor. It's, yeah. And actually in the state system, there's an executive team that has to like come together and agree. And yeah. So, because it is a judge, it's a legal activity.
I guess what I have very limited understanding of the MH1 to MH6, but you know, my son will frequently, you know, he has a diagnosis of schizoaffective disorder, neurocognitive disorder, TBI, and methamphetamine dependence.
Okay.
And he will become very unstable. And so it seems if he'll call crisis, at least he will do that, and they will come. And if they take him to the hospital, many times he gets admitted. If he takes himself, many times he doesn't get admitted, but if a crisis worker takes him there, or the police take him there. But I thought that with the police take him there, it's an MH1 and he's to be held at least 48 hours. But I think in Hilo is more of a small psychiatric unit, more of an acute.
Mhm.
If they get him stabilized on meds, he's not, you know, sometimes it's so brief, the stay, and to
Right.
discharge him, many times he's right back to being unstable in another 24 hours or so. It's just really kind of frustrating, but I didn't know what these different levels meant. If, you know, if someone's MH2, does the hospital have you know, what does these levels mean? Is it who brings him in? Like, is, you know, the police brings him in, that's an MH1, 48-hour hold. I don't know that, you know, if that's definitely the definition of it, but I'm just trying to understand how he would qualify for a different MH level, and would that mean he'd get a longer hospitalization stay, which would help in his stabilization? That's my question.
Okay. I do have a whole sheet that has the MH1 to MH6 definitions. I could send that to you, or maybe that'd be the best.
Okay,
Yeah,
I'll put my email in your
okay.
chat. Is that?
Yeah,
Okay,
yeah, that'd be good.
thank you.
I think my email is at the end of this too. Yeah, no, I can get that to you. And trying to think of any other suggestions for, yeah, they just kind of vary a little bit. But I think that it'd be easy to run into that same problem of, unless somebody's gonna come over here to Hawaii State Hospital, we do get some people over here that are from the neighbor islands, and then they even go through treatment here and then finally return. But yes, I know it's frustrating to not have too many choices of where people can go. Although you do have one of these in LCRS, you do have a licensed crisis residential.
I don't know if I'm unmuted. Can you hear me?
Yep.
Yeah, we do have one house for the entire island with 10 beds.
Yeah, same here.
There is, sometimes that happens, that he gets a step down to the LCRS if there's a bed available. If there's not, he doesn't. That's what happens.
Okay. And then let me just quickly go through these. So these are other state operated supervised residential program. There is one here on Oahu. This is generalized statewide. So community-based case management. That's when somebody's in the adult mental health division system, or even a private provider. That's pretty common. People, this is what you want to have for your person is, you know, a case manager. It's a very case managed driven system. And then everybody would have a recovery plan or treatment plan, and those do get reviewed. So that I mentioned earlier, you want to try to have you want to be involved with that. And then this is kind of new, the temporary quarantine and isolation centers. This is because of COVID, and then also crisis stabilization beds. So there's about 40 of these, no, actually 52. There's some on the Big Island. There's some, there's many on Oahu, but these crisis stabilization beds are meant to have a place for people to stay to avoid going to Hawaii State Hospital. So these are very important additions, probably in the last year or so, to, again, avoid hospitalizations. So those are some kind of lingo that's going on. I did that. Let me kind of, I hate to speed through this, but some concepts. So there's state operated services, and then there's purchase of services. So you'll hear people talk about, well, is that a POS? That just means it's a private agency. It's called a purchase of service. Utilization management. So this is what kind of drives everything. It's the people that work in where the consumer is going to go, you know, where, based on kind of how they use the system, where they should go next. And that's a whole department within adult mental health division. And so I didn't even know what utilization management was until I went to the division, and I was like, wow, that's actually a very significant function, because you know, they have the whole picture of every consumer, every person that's in the system and where they are and where they're gonna go. So discharges and transfers and intakes, and so it's just a function that you should kind of know exists. I mentioned treatment plan and treatment meetings. Then the old days we used to call them community mental health center, CMHCs. Well, now they're called treatment service sections. Community-based case management. I mentioned the consents and the way of information exchange. Try to get your name on any consent or release. Inpatient and outpatient services. So that's kind of how the system is also divided. And then supported housing and level of care. So these decisions around supported housing and level of care, things are kind of divided again by level of care. So could somebody be in an 8 to 16 house? What that means is how many staff hours there are on site, or could they be in a 24-hour house? That means that's high intensity. That means that their level of care is requiring that a staff would be there all the time. In other words, they can't really live on their own. They need that kind of supported housing where there's a staff 24/7. So the goal is that, say somebody comes out of the state hospital, you slowly transition them to then say a 24, and then an 8 to 16, and then, you know, maybe eventually more independent. So there is kind of a method to the madness that, you know, people are striving to get people in the least restrictive environment. And there's different rules according to that too. You know, the 24-hour is going to have people assist. You can't give medication, but you can assist with medication. And, you know, in another kind of housing, you would take your own meds. So there's all kinds of these little complexities that the consumer has to get used to and adapt to, but also depending on how involved the family is, the family goes through all that too. This is just a slide about that COVID has really exposed a lot of challenges and kind of even some weaknesses. So just to, you know, have a little empathy for some of the providers, you know, sometimes the providers, you know, we didn't have enough computers, didn't really know how to use Zoom or Teams, and nobody's very good at self-care, probably not you guys and certainly not us. And so it has been a very tough time. We've had to learn a lot of new technology, and learning new things while we're stressed, that's not the best time to learn. So it has been challenging with that. But there's also been some strengths. You know, I think we have learned that we're more resilient. We've learned some virtual options that nobody ever thought of. Like we've got a lot of clients going on AANA online, Facebook webinar trainings. I love the focus on cleanliness. I've always had kind of a thing about, you know, just because we're you know, we have these mental health environments doesn't mean I don't want to look all dumpy, you know, let's try to spiff things up. And so that's been kind of a treat. We've partnered with other people more than ever. And then I find we have to be really clear about communicating, because I don't think I know that we're not all at our best because there's so much going on. And it's been time to have some times of gratitude as well. Medication is a really important topic, I know, with consumers, but I'll tell you, this is something, it's a really personal decision, I think, for most of us, that to have a relationship with the doctor and then to really decide, this is my medication box and with my meds, that, you know, one has to kind of take that on themselves. No matter how many people tell you that you got to take it, you must take it, you're going to go back to this hospital if you don't take it, all those threats and problems, each individual has to kind of find their way about their commitment to take medications. And so I just want to mention meds because that's
Can I
so-
just share really quick that there is a dispenser called Hero. I highly
Yeah.
recommend it. Everyone should go online and look at it if you have as many medications as you do. It was very helpful with my son until he became psychotic and it didn't work anymore. But it was almost a year and a half of compliance, hugely different. So I highly recommend it if
Oh my gosh.
if your loved one is in a home, you know, like in your home or in their own home. Of course, if they're on the street, it's useless. But thank you. Just wanted to make sure I said that.
Oh, thank you. Hero, like hero.com, we could find it?
Yes.
Okay, thank you. I'm looking for your name on it. Will you introduce yourself again? You've said
My
something.
name's Karin, Karin.
Okay.
Hi, everybody. Sorry, all it wants to do is give you a picture of my bed. So
Karin, where are you from?
I'm in Kawaii.
Hawaii, okay.
And I'm in the exact same situation with Susan, although my loved one has been ill for 15 years, my son. He's now on the street again. And the biggest thing I wanted to just say that I'm having trouble with is that because of our huge amount of meth in the state of Hawaii, and the way that the hospitals respond to that is a whole new animal. First they started calling schizophrenia schizoaffective when there were street drugs involved. That happened about 10 years ago. But then that immediately gives them a label to treat you as an addict, not someone with mental illness. But now, if they find out that you're using meth or that my son is using meth, they basically tell him to stop using meth and go take his meds, and they won't admit him in the hospital, in the mental hospital. So it's a problem, and our government's involved with that. You know, we have a police department that I think is corrupt. And so it's very difficult to deal with something that is such a huge problem. I have to stop. I know you don't have any time. Thank you very much.
Thank you, Karin. And I'm glad you're with NAMI. And yeah, because you and Susan, for example, having that in common, and other people I'm sure can relate. We have to stick together. And yeah, Kawaii, there's very little there. You've got that one hospital, and then I know there's only the mental health center and one other provider. There's not much there. Yeah. Oh, thank you. I'll just quickly add these. A little something about peer support. You know, people do really well when they do have other friends in similar circumstances, just like families. Here's a thing about improving mental health, little things about improving mental health. And then this, I want to make sure you see this about Hawaii Cares. I'm sure you probably do this, do have this number. This is a new service that if you call Hawaii Cares, you can ask for kumakani, because it's it's confidential. No data is really kept on people except for just geographical. And people can just talk story, because COVID's been so stressful. It's just another avenue for people to talk to somebody. And so it's a great new project. It's funded because SAMHSA and FEMA for disaster relief. And so I encourage you to tell your friends and use it if you need to, anybody. This is a little bit about it, anonymous, kind of the stuff I just said. And then this is my last one, which is, you already know about MHA and NAMI. Here's a couple other favorites. This is a DOH website. What else do I have here? American Foundation for Suicide Prevention, lots of really good resources there. And then this is more about substance abuse. So all kinds of stuff. Those are all on my favorites